Good afternoon, everyone. Thank you for logging in. Welcome to the Echo Hub under Ministry of Health, Hepatitis B team. So we'll be starting our session. It's now 14:31. So those that are yet to log in, or please invite a friend, make sure that they're logging in so that we have a beautiful time of learning and discussion. As we are waiting for our expert presenters to come through, especially for our first presentation, please feel free to log in, say hi on the chat, feel free to ask questions on the chat. We are excited and we're going to have a fantastic learning period this time around. We are discussing hepatitis B in pregnancy, and we have everybody logging in from all over Zambia. Please let us know in the chat room where you are logging in from, where you're listening to us from, so that at least we get interactive. Otherwise, welcome and looking over to actually having a lovely presentation and a lovely learning experience. So we have our first presenter. Dr. Vinika, are you there?
Yes, I'm here. Can you hear me?
Yes, we can hear you. Are you ready to give us the first presentation? So far we have about 122 people that have logged into this session. I think we are good to go, or would you like us to give it a few minutes?
I'm ready when you are.
Okay, let's give them another 2 minutes so that at 14:35 on the dot, we start.
Doc, will you be controlling my slides, or do you want me to share from my end?
If you're able to share from your end, please feel free to do that so that at least it's easy for you to move at a pace that's okay for you.
Okay, I'll do that.
Okay, we have 1 more minute to go. Say hi in the chat room, let us know where you are listening from. So we have Choma listening in. Thank you, Choma, for tuning in. We have Western Province, Lushinga logging in. We've got Sesheke there, we've got Katete. Livingston has logged in, this is awesome. Railway Clinic is on, we've got Minor Soccer that has also tuned in. Oh, and we've got Itech Sage that has tuned in. Thank you. It's awesome that network has actually connected from there. Awesome. We've got Ndola Teaching Hospital logged in. Lundazi District, Cedric, Chililabombwe. Wow, this is amazing. All right, thank you. Please, let's keep the chat room going on. Today, I would like to just introduce myself. Dr. Christabel Mbiza is my name. I'm a registrar in the Department of Obstetrics and Gynecology, Women and Newborn Hospital, UTH. So we are discussing hepatitis B virus in pregnancy. So we'll have our first presentation from Dr. Michael Vinico. So Dr. Michael, please feel free to keep the ball rolling. Over and out to you.
Okay, let me share my screen. So I find that it's actually a little easier to show my slides like this rather than at full screen so I can see what's coming next. Thank you very much for your attendance. So as Dr. Mbiza and OBGYN has hinted, we're going to be talking about hepatitis B in pregnancy and how to prevent it in babies today. So the 3 learning objectives are: number 1, to learn about strategies to integrate hepatitis testing into antenatal care and perinatal care. Number 2, learn about the prevention benefits of the hepatitis B birth dose vaccine and the existing EPI vaccines. And 3, to learn about the eligibility and management of maternal antenatal tenofovir. So this is this figure really just kind of tries to represent the antenatal and postpartum periods for the mom and the baby. So as you can see in the green, we have the 3 trimesters of pregnancy, first, second, and third. Then L&D is in orange in the middle, that's labor and delivery. And then yellow is the first year of the baby's life. So we talk a lot about hepatitis B in Zambia, and most of what we talk about is testing and treatment. But when it comes to prevention, we really want to focus in on one specific population, which is newborn babies. The reason for that is that newborn babies have immature immune systems. And so if they get exposed to the hepatitis virus, they are very likely to progress on to a chronic liver problem that can end up with cancer or liver failure when they become teenagers or adults. And so on the other hand, if an adult, such as a health worker, gets exposed to the virus, let's say, while you're taking care of a patient, your chances of getting the chronic hepatitis that can progress on to cancer or liver damage is very, very low, less than 5%. So we're looking at, babies carrying a lot of risk compared to adults. And so while we do want to prevent all hepatitis B infections, in Zambia, to achieve our goals of our program, we really need to focus on prevention in babies. And so I just want to talk about the different periods here I have on the slide, because things are looking a little different than they are in HIV. So for example, you can see here in the green, during pregnancy, actually in this period of time, transmission to the baby is rare. What we call in utero transmission is really, really uncommon, and it is not really considered a major factor. So that is because, the virus does not freely cross the placenta and infect the baby. And so typically we're not worried about this period of time when it comes to mother to child transmission. But where things really happen is at labor and delivery. So as you may remember from previous presentations on hepatitis, the way hepatitis B is transmitted is through exposure to blood from an individual with hepatitis B or exposure to their sexual body fluids. And so when you're being born, you're exposed to your mom's blood and body fluids at that same moment. So that is the period of most risk to babies, is labor and delivery. And so that's really the highest risk moment. And then subsequently, there's also some risk in the first year of life because it takes time for the baby's immune system to mature. And so if they get exposed during that period of time, again, they have a 50 to 90% chance of the chronic infection. So I would say the most critical period is labor and delivery, but if the first year of life also presents some concern. So let's talk about the first, what we call proven PMTCT intervention. These are proven interventions that have been studied in clinical trials, either in Zambia or in other countries. And so the first one is to vaccinate the baby when he or she is 6, 10, and 14 weeks of age. And so those of you who work in the EPI program, you know very well that this is when we provide the pentavalent vaccine to all the under 5s who come through. So we start this at 6 weeks of life, and there are 3 doses of the pentavalent at 6, 10, and 14 weeks if they're done on time. And the pentavalent vaccine, ever since 2004, has included hepatitis B, which is a really good thing. I'll show you. And so this was the first strategy. So the strategy, first thing we did in Zambia was we tried to knock down transmission during the first year of life, this yellow area. And so now at this point, I believe more than 90% of babies are accessing these EPI vaccines. And so transmission in this period is going down. This worked very, very well. You can see here in the Zamfia survey that the Ministry of Health carried out together with a lot of partners. In 2016, everyone who participated in Zamfia had a hepatitis B test. And so this allowed us to look at hepatitis B positivity. That's the infection positivity by age in children. And so you could see that overall, about 1.1% of children were positive, but you could see when you break this down by this red bar, you can see that the children who were 0 to 9 had 0.7% prevalence, and 10 to 14 had 2.7% prevalence. And so what happened at this red bar? This red bar represents the introduction of the vaccine for those children. And so although this is not a perfect analysis, I think it's pretty clear that introducing that vaccine into our EPI program back in 2004, 2005 led to a reduction in hepatitis B in infants, in children. So we know that that works very well in Zambia. So that's wonderful. So basically, as a program now, we believe that probably if we were to assess under 5s again, we would find about 0.7% prevalence of hepatitis B, which is wonderful because in adults, we know it's 5%. So it's about 1/10 as common now in young children as it is adults. Okay, but from the elimination of hepatitis B perspective, which is something that we're striving for by 2030, the target that we are adopting as Zambia is to actually cut it all the way down to 0.1%. So that would be 1 in 1,000. So right now we're at about 0.7%, 7 out of 1,000 children. And we want to cut it down to 0.1% or 1 out of 1,000. This is what we consider to be hepatitis B elimination, or elimination of mother to child transmission of hepatitis B. And so this is what we're striving for in the next 7 years. So how do we get to that level? Well, before I talk about the next round of interventions that we're thinking of, we get to our first poll, and I'll pass it back to Dr. Mbiza.
Okay, so we are on our first poll. Thank you for those that are still tuning in. We want to welcome everyone. We are having the Hepatitis Hub Echo under Ministry of Health. So the first poll says, which of these is true about hepatitis B vaccine within Zambia extended program on immunization? 1, hepatitis B vaccine is given at birth and 9 months of infant. 2, the program has reduced hepatitis B vaccine prevalence down from 27 to 7 per 100,000 children. Number 3, although 3 doses are recommended, 1 is sufficient. Number 4, increasing the completion of the rate of HBV vaccine series will lead to hepatitis elimination in child. So please feel free to answer. The poll is ongoing. Pick what you think is the right answer from those. So the voting is going on. We are at 37%. 40. Okay. We're now at 55. We'll be ending the poll. Okay, we've ended the poll. Thank you so much for those that managed to vote. So we have 61% who think that increasing the completion of the vaccine, that is at 61%. And then 27% thought the answer was number 2, that the program would be reduced. And then 6% thought that giving the vaccine from birth and 9 months would reduce. And only 5% thought otherwise, that all 3 doses may be recommended, but 1 is sufficient. So let's see what the correct answer is.
All right, great. Thank you very much. Well, the correct answer is actually number 2, that the program has actually reduced quite a lot the transmission to children. However, number 4 is not true, because the completion rate for the current vaccine series is already very high, and increasing that rate slightly more will not, unfortunately, lead to hepatitis B elimination from mother child. Remember what I said here. We give the vaccine to the infants at 6, 10, and 14 weeks of life, but the highest risk period is at labor and delivery. And so really there is a window that is being missed from labor and delivery all the way through to 6 weeks of life. And that is where we need to tackle the additional cases so that we can achieve elimination, which is defined by less than 0.1%, or less than 1 in 1,000 children born. So the proven intervention number 2, which can help us in this way, is what's called the hepatitis B birth dose. So it's the notion of giving the infant an extra dose of the vaccine right at birth, even before they reach 6 weeks of age. And this works because, again, just like any vaccine, it stimulates an immune response, which can provide protection against the virus. And studies have shown that the best time to give this is actually as soon as possible after birth. So even within hours of birth, ideally, it's recommended within 24 hours. So this is strongly recommended by international experts, because just by providing this extra dose of vaccine, we can make progress towards hepatitis elimination. We can get it down from the 7 out of 1,000 down to 1 out of 1,000. We may not make it all the way, but we will make improvements by giving this extra dose. So it sounds straightforward. You just give the baby a jab at birth. However, there are a number of operational challenges. And at present, this vaccine is not available at Ministry of Health facilities. You can only find typically the hepatitis B when it's co-formulated into the pentavalent vaccine, which is of course only indicated at 6 weeks of life. So we don't want anyone to start giving the pentavalent to a newborn baby. That's not correct. But in the near future, we hope that the Ministry of Health will start stocking the vaccine that's just for newborn babies. And it's a hepatitis B standalone vaccine. But at present, most clients that we have in our hepatitis program, unfortunately, they have to find the resources and purchase from a private pharmacy. And the price there can range. I've seen it around 70 kwacha, but it can go even to 200 kwacha sometimes. So it's quite a big expense. And it requires, a lot of counseling and discussion in the family to raise that kind of money. The other concern with providing this is that we don't really give vaccines immediately after birth. We give them in the first week of life, such as the BCG or oral polio, but this does require some new programmatic approaches and some synergies between MNCH and the EPI program. And then the third and very big challenge is that, of course, many women don't deliver in the facility. So how would you possibly give them, their babies, a vaccine within 24 hours? So this is something that you're going to be hearing about more in the future as we work through how to implement this. But once it's put into place, it's a very low cost intervention because the vaccine is very safe and it was developed more than 15 years ago and has great safety data. And so I think it will become the standard of care in the near future in Zambia once we work through some of these operational challenges. And now I'm going to move on to the third intervention, which will help us to eliminate hepatitis B from mother to child. This is called HBIG. So you can give the babies a dose of something called HBIG, which stands for hepatitis B immunoglobulin. And immunoglobulin is essentially a cocktail of antibodies which has been developed by a blood bank or a blood bank-like facility, which the antibodies protect the person against hepatitis B. And so, as you can imagine, this is quite a sophisticated product. It's injected in an IM form, and just like the birth dose, it needs to be given right away after birth. So ideally for HBIG, within 48 hours. And this provides the antibodies to the baby so that if the baby is exposed to the virus at labor and delivery, that the virus can be bound up and not infect the liver. But as you probably can imagine, the HBIG, although it's a proven intervention, is really not a feasible possibility for us in Zambia because of the expense. And, and generally, excuse me, we really don't even find it in the private pharmacies at times. When we do take care of clients who have resources, even sometimes they struggle to procure it on their own. So although this is proven intervention, it's not likely to be taken to scale. Whereas the birth dose, I believe, will be taken to scale in the next years in Zambia. So now let's go on to the fourth intervention, which I think will make people more interested because it's highly feasible for Zambia. We can start doing it immediately, which is screening and treatment of moms antenatally with hepatitis B antiviral therapy. So as I mentioned, let's go back to my first figure. The transmission in utero across the placenta during the first, second, third trimester is quite rare. But the transmission does happen right at labor and delivery. And so here we go. So if you were to test mom during the second trimester or even the third trimester of pregnancy, and you find that she is at high risk to transmit, you can initiate her on tenofovir therapy with the goal of preventing the transmission during labor and delivery. And so for those of you who haven't attended a hepatitis echo before, we use tenofovir because out of all of the ARVs we have in Zambia, this is the one that was found to be really good at also treating hepatitis B. So there are many ARVs like dolutegravir, efavirenz and others, which only work for HIV, but tenofovir is wonderful because it can work for both HIV and hepatitis B. And this is both the old tenofovir, TDF, and TAF, which is the newer tenofovir that you know increasingly now. And so, so one of the proven interventions has been to test moms and give them the tenofovir during the pregnancy so that they can reduce transmission. And this really follows along the lines of HIV. So this is a big teaching point for everyone to take note of. So again, I think it's very similar to HIV, but what we know in hepatitis B, especially in Asian data, we don't have much data in Africa, is that the mom's hepatitis B viral load during the pregnancy is the #1 risk factor that she is likely to transmit to her baby. So this is a systematic review and meta-analysis, and each blue dot represents a study that was done. And so you can, and then on the on the y-axis here is the percentage of mother to child transmission. So you can see that when the when the viral load reached 10 million copies or 10 million international units, transmission could be as much as 30%. But when you get it down to about 200,000 copies, it's about 10%, and below 200,000 copies, there was actually no transmission in those studies. Okay. And so this is the World Health Organization, and even in our guidelines in Zambia, had concluded that when moms have a low viral load less than 200,000, and in these studies, the baby received the birth dose and the HBIG. In those studies, transmission did not occur. So this threshold was developed, this 200,000 threshold. So now everyone wants to get the mom's viral load in pregnancy below 200,000. And that is the real push on the international scale. So we as a hepatitis program, we tried to look to see what are the viral loads of our women in Zambia? What are we seeing? And it was striking. We only found records for 20 pregnant women where we had all of their clinical data and their viral loads. And so here you can see the viral loads for 20 pregnant women in Zambia. And these are HIV negative women, I believe. Only 3 of them, represented in the dark orange, had the high viral load more than 200,000, whereas others had lower viral loads. So only 3 out of 20 really had this high viral load. All right, so now we're going to go on to poll number 2. And I will then come back to.
Okay, so we're on to the second poll. Thank you all those that are still logging in, and we're at 313. So poll number 2 says, which of these is true regarding hepatitis B for mother to child transmission? Number 1, most hepatitis B transmission occurs in the second trimester. And then number 2, an extra birth dose vaccine is only recommended for mothers below the age of 21 years. Number 3, maternal viral load during pregnancy is a strong predictor of mother to child transmission. Number 4, women with HBV should not breastfeed their babies. So which of these is true regarding HBV mother to child transmission? So please take to the polls. Okay, so we'll be ending the poll soon. Keep those answers coming. So we are ending the polls. Thank you for your active participation. So 84% thought that the viral load, number 3, was what the true answer is. Then 12% thought that the most HPV transmission occurs during the second trimester. 4% thought that women with Hep B should not breastfeed, and 1% thought an extra dose of HPV vaccine is only recommended. So let's go back and see what the true answer is.
Yes, the 84% were correct that the mom's viral load during pregnancy is the strongest predictor we have that she will transmit the hepatitis B to her infant. So, as we talked about, there's this international recommendation that moms with a high viral load of 200,000 and above should go on to the antenatal tenofovir during pregnancy, because the opinion of the international experts is that even if you have the H big, even if you have the birth dose in your country, you still need some additional interventions for these women with the highest viral loads. So now my next slide is called WHO guidelines, hard to adopt and implement. So although this is, again, it's wonderful to know what the trials have shown and what the global experts recommend, a lot of times we have to think practically, and we have to consider implementation factors in what we do to make sure we have the most impact possible and we don't miss opportunities. So the first point here is that virtually no one in Zambia, none of you on this call, have the viral load test available at your facility. Now, you might be aware that the Gene Expert machine, as well as any of the large HIV viral load platforms, they can all run the hepatitis B viral load. It's just a matter of reagents. So it could be something with the right political will and funding that we could do in the future. We wouldn't need to buy any new equipment, but it's really not available. And so we as clinicians are blind to the viral load when we see a pregnant woman with hepatitis, typically. The second point is that these guidelines don't really apply to our setting very well, because the data came out of Asia, where the virus has a different genotype, where women have different viral factors. For example, the E antigen remains positive usually in pregnancy in Asia, and the E antigen is negative usually in our setup in Zambia. Then also they have had the birth dose for many years plus the H big, and so this this threshold that they came up with is really not the right threshold probably for population here. We don't know what the right threshold is actually. And so really there's a need for more information about this. And at the same time, we are very expert at prescribing and using tenofovir to treat viral infections because of our success with the HIV program. So we have we have tenofovir stocked at almost all the ART departments, or all of them. And we know its safety profile. We know how to screen for identify kidney problems if they set in, and other side effects. And so we have a lot of experience with this medication. It's just sitting there in our pharmacies. So there is that tension. So now with my last 3 slides, let me go through the Ministry of Health guidelines, which were codified in 2019 for hepatitis B PMTCT in Zambia. So what was recommended in the guidelines was that at the first antenatal visit, that if possible, integrated testing should occur. So the pregnant woman should be tested for the hepatitis B surface antigen, and that the women should be counseled about hepatitis if they're positive. Women who are newly diagnosed, they should have some basic blood tests, which are recommended for all people with hepatitis, such as the full blood count and the liver enzymes, in order to check for liver damage, which would be an eligibility for treatment. And then at present, we really recommend the birth dose. However, in practicality, this means the moms need to procure it on their own because very few facilities keep this in stock on a regular basis, although it does happen. And typically the moms try to buy this before they go in to deliver, and they carry it with them in their bags so that as soon as the baby is born and before they leave the facility, they can be injected with the vaccine dose. So that's what we recommend at the first antenatal care visit, that those discussions happen. Then as far as what to do at the subsequent antenatal care visits. So we do recommend starting tenofovir therapy if there's an indication that the mom has some sort of liver damage where she could benefit for both PMTCT and for her own health. So that would be if there's a raised ALT, if the platelet count is low, which can be a sign of cirrhosis, which is advanced liver disease. If the APRI score is high, and I won't go over what that is, but we went over on a previous echo session, that's another sign of liver damage. Or if the client does have access to the viral load, again, a high viral load would be an indication to start therapy. If you do want to initiate treatment during pregnancy, you can give what you have available. So that's usually TDF plus RTC, because usually those are co-formulated, or TAF with FTC. And I would also say, although this is not in the guidelines, that if I had to start treatment and I only had TLD available and I was going to give it to a woman, I would also consider TLD, because even though the dolutegravir has no effect for hepatitis, on a practical level, it does treat hepatitis. The other two drugs will treat the hepatitis, and dolutegravir we know is a very safe medication. And my other, so I think the tenofovir preparations that you have should be sufficient. And then on top of this, we do acknowledge that we want to give clinicians their own discretion as to starting treatment, especially in light of all the uncertainty around this viral load threshold, the lack of the birth dose, non-facility delivery. And so there are times when we do prescribe for a woman where we don't think she's going to manage to secure a birth dose, and it gives us some intervention to prevent transmission. Also, if the woman is traveling or we're worried about her retention in the full cascade of care, including facility delivery. And finally, there's always an important, another important advantage of giving tenofovir to these pregnant women with hepatitis B, which is HIV prevention. So pregnancy, as Dr. Mbiza and many of you other experts will be aware, pregnancy is a period when HIV risk goes up in pregnant women. And so there is an added advantage of treating the hepatitis. You can not only prevent transmission to the baby, but you can keep the mom HIV free during the pregnancy. Now, let's say you have started treatment on a pregnant woman. So if she had started for the purposes of PMTCT, she can discontinue at 6 weeks of age, when the baby is 6 weeks old and is now coming in for their EPI vaccines. So you could continue it up until that point, and then the moms can discontinue treatment. And so this is another culture change, because in HIV, we never discontinue treatment, whereas in hepatitis B, for the purposes of PMTCT, it's okay to give treatment for a limited basis just to cover the labor and delivery period particularly, and then that can be discontinued. But after stopping treatment, again, a lot of counseling is required to make sure that moms do come back for reviews, because there are times when there can be a liver flare-up, when they might need to go back on treatment because of hepatitis. And of course, in a subsequent pregnancy, they may need to go back onto it. And then what about the infant? So the infant who's been exposed to hepatitis B should only be tested at 6 to 12 months with a hepatitis B surface antigen test, which is available at most of your facilities. And that should usually, by recommendation, should be done after they have completed their pentavalent vaccine series, at least 1 month thereafter. And so we don't do any testing at 6 weeks or at birth. We really wait till 6 to 12 months to check the baby, and then that is your evidence of mother to child transmission. You can, there's no PCR necessary. Even the surface antigen being negative will confirm that there was no transmission. And that was my last slide. So let me pass it back to Dr. Mbiza. Thank you so much for staying on the call.
All right, thank you so much all for listening in. It's been a beautiful session. For those that are joining us, thank you for joining in. So we will take a time of discussion. I see other people are putting up questions in the chat room. Let's see how many of those we can take up. Okay, so I'll start with the one that I have from Irene. Do we recommend tenofovir monotherapy or tenofovir lamivudine or amitriptyline combination? Don't we have tenofovir monotherapy? The other question from Nadi is, how long after commencement of treatment with tenofovir does the viral load drop to less than 200,000 units? So those are the questions that I have so far. I have a hand from Kelvin. Please, can you unmute Kelvin so that we take a session of 3 questions and then we move on from there.
Thank you, Dr. Biz, and thank you for that presentation. I think my question is just trying to look at the interventions. When I looked at the data, we are saying we have most of our new infections, I think above the age of 10, if I remember correctly, with a 0.7% below the ones that are at birth and going onwards. So I'm wondering where we should focus our interventions. Should it be beyond the 10 years age group or afterwards when our children are getting infected? That's one. Then 2, why are we having a high positivity above as the children are growing older, despite having the Hep B vaccine? I think most of our children do receive, I think we have over 80% immunization rate, receiving all the 3 doses at 6 weeks, 10 weeks, and 14 weeks. Thank you.
Okay, thank you for that lovely question. Dr. Vinegar, any of the experts, would you want to take up that?
I think Dr. Chambwa is ready to pick up some of the questions.
Okay, can we unmute Dr. Chambwa?
Hi, this is Dr. Chambwa. So I'll probably answer Dr. Kevin Zimba's question first, the one where he was asking about why we're still seeing hepatitis B in those less than 10 years, despite the fact that we've had the vaccine for over 10 years. So after the first poll question, Dr. Vinico explained that part of the challenge is that the vaccine is given at 6 weeks. So there's still that period between birth and 6 weeks when children may get infected either right at birth or as they're breastfeeding if the nipple is cracked, or there's other reasons to get infected. So basically, even though those children get vaccinated at 6 weeks, you're giving a vaccine to someone who's already infected. So for those who get infected, then the vaccine will not really be of great help. So that's the reason why there's still some some infections despite the vaccine being available. And the solutions that Dr. Vinick was outlining are some of the things that could be done to reduce that infection in that interval between birth and 6 weeks. And what was your other question, Dr. Zimba? I think you had tied it into another question, so that I deal with both of them.
I was looking at the positivity between the two age groups. It was 0.7 for those below 1. So which means then it was higher above 10. So it means that they are getting infected beyond, not just the 6 weeks, they're getting infected beyond that age group. So I was wondering
No, what it meant is that those that are 10, so they probably got infected before the vaccine was widely available. And Dr. Vinico, you can correct me if I'm wrong, but what I understood is that the older children may have been born at a time when the vaccine, because even when a program is introduced, it takes time for it to really saturate and have everyone get the vaccine. So the older the child is, then the more likely that they were born at a time when either when the vaccine was just being introduced and it wasn't as widely available. And but there's still that gap from birth to 6 weeks. And then I can probably take Dr. Walia's question as well, Dr. Erin Walia, where you're asking about tenofovir monotherapy. So the reason TAF or TDF was mentioned, TAF or TDF which was mentioned, is that that's what's widely available. If monotherapy, tenofovir monotherapy was available, that would obviously be a good option. But people are already used to getting Truvada or Tafed, the one which is combined. So just from a public health point of view, it's easier to use something that's already available and people have familiarity with. I think those are the two that I'll take over.
Okay. So there was the question about how long after giving treatment would the viral load decrease to less than 200,000 units?
Yeah, I can take this one. Well, we believe we should have a 1 log reduction per month at least. So so if the viral load is is very high, you would want to give yourself a few months of treatment before labor and delivery. So the guideline is typically at 28 weeks is when we start the antenatal tenofovir. So I don't, I think 1 to 2 log reduction per month of treatment is what people believe typically. That of course depends on adherence. Over.
Okay, thank you so much for those responses. So we also have another question asking to say, do you give tenofovir without regarding the renal feedback? That is one. Is there a hand up? The second question says you said that you have to discontinue after 6 weeks if mother has started PMTCT in first trimester. How can you tell if the mother viral load is still high and she's not capable of transmitting to the baby? That's the second question in our polls. If we had a hand up, can you kindly unmute the person so that unmute yourself, then ask the question? We've got one.
Hello, good afternoon. This is Episo. It's 2 questions. One has been answered about the HB or HB vaccine at birth. But the other one, I wanted the mic also to clarify on now. I saw a question regarding breastfeeding during with regard to a mother who is positive for hepatitis B virus. Is it advisable to breastfeed regardless of the viral load? So for instance, it's above 200,000. Is it advisable for the mother to go on and breastfeed? Then the other question, maybe you can even combine it. How available is the test tool for viral load in our settings that they are in these facilities, that we have machines that are able to test for viral hepatitis B viral load? Thank you very much.
Okay, any of the experts to take the questions that have been posed before us?
Dr. Christine, I can try and chip in on those two. This is Kawana. So on the question of how safe is it to breastfeed when a mother had Hep B during pregnancy, and I think there was a mention of a viral load above 200,000. So I'm sure from the presentation, though I joined in a bit late or another meeting, it was clear that that's the whole essence why we also want to give the MTCT, the PMTCT. We want to reduce this viral load to a point where it becomes almost the chances of transmission then become very, very, very slim. And then also, if you look at what the current guidelines say, whether they are European or American guidelines, they actually do not discourage breastfeeding, even if the mother was Hep B positive during pregnancy. Yeah, and as you're aware, these guidelines are born out of, I think, a number of studies that people have done to see the pros and cons. Remember, in Africa, you not breastfeeding a child may also have other implications outside even the hepatitis. So you may have more complications from this unbreastfed child from a mother who may not even probably afford formula and all the other things. So I think we have to look at what the guidelines say and also look at if you don't breastfeed, what happens next? Yeah, so I think it's safe because the guidelines provide for that as well. Then I think the other question was, just remind me, what was the second question again from Kelvin?
Oh, sorry, Melvin here. So I was asking how available are the testing facilities for viral load for hepatitis B?
Thank you. Yeah, so how available? Obviously, we have facilities within the country that can do viral loads for hepatitis B, but by and large, most of these are, like private labs, so to say. Yeah, mostly within government institutions. Almost everywhere else, it's a bit difficult to get these assays done. Yeah, but where people can manage to, pay for them, we should also already know as a country that they are available. I mean, we run these clinics where we actually follow up patients that have these results. But in terms of the government institutions, maybe not as available as would like them to be. Yeah. Thank you.
Okay. Dr. Negos, to make a comment, please go ahead, Doctor.
Good afternoon, everyone. As introduced, I'm Dr. Monenga. I'm the PMTCT coordinator, national coordinator. Maybe just to comment that we'll be working as PMTCT, we'll be working with the Hep B, the E18s, so that from our program, we are transitioning. We're in the process of transitioning from the HIV syphilis MTCT or EMTCT to actually triple. So with the triple, they are actually in Hep B, in the public health sector. And I know there are challenges, but of course, to every challenge, with key stakeholders, we should be able to define the direction for PMTCT. Yeah, so we will be calling out our initial meeting that actually developing the operational plan for PMTCT. And I think we have had informal discussion. Michael and hepatitis B, and we should, so that we can actually pass for EMTCT.
Thank you so much. So we will move on now. There's one question. I think we'll integrate this one after the case presentation. So we can go to our case presentation, and then we will get back to having more of the interaction together. Okay, so we'll do a case presentation for one of the cases we had during our hepatitis clinic. So a female age 37 on Hep B mono-infected. She was para 2 post-delivery in May 22 at a private facility. That was initiated on Truvada the week she delivered. And the patient became depressed and stopped taking the medication. From what we have in terms of the past medical history, it was unremarkable. This was a woman that was married, and she had just presented with this depression post her delivery in May. So we'll look at what her labs looked like. So we had labs that were taken. ALT was 16, AST was 14, creatinine was at 47.9, platelet was 347, and her Hep B DNA copies were at 18,830. So our questions in terms of just basically trying to steer up a discussion was the initiation of the Truvada okay? If yes, on what basis? And the second is, should she continue with, how should we do the follow-up of the baby? And since she's depressed, should we change the regime? And another thing we're looking at basically is just trying to see what other follow-ups can be done in terms of management of the mother. So let's just steer up the discussion. Feel free to unmute yourselves. Let's get interactive with this mini case of this patient we came across who was on Hep B monovalent and had delivered and was on Truvada, and the copies were 18,830, and she was on Truvada. Is that a question? Hello? Okay, so we'll point out from any facility. From Dollar Teaching Hospital, please. Your thoughts? Dollar, Levy. This covers nationwide, so let's get interactive. What are you doing in your facility? How are you managing these women? Okay, we'll give it to the experts. Okay, can we get one of the experts to take it up, please?
Yeah, sure, I can take it up.
All right, awesome. Thank you so much for that response. Please go ahead.
Yes, I think that, would you mind going back to the labs?
Okay, we're at the labs.
Yeah, so this is this is exactly the woman where it is a high risk situation, because even though the baby is going to get the EPI vaccines starting from 6 weeks, the mom's viral load is quite raised, 18,000. And it doesn't reach the 200,000 that was recommended in the WHO. But again, remember that threshold is only for women who are in clinical trials in Asia, where the HBig and the birth dose was available. So if I saw that viral load, I would say this mom needs to go on to the tenofovir during pregnancy. So I agree with that. But unfortunately, in the real world, you would be blind. You might have those other lab results. You might see the ALT of 16, the creatinine of 47, and the platelet of 345, but you wouldn't see the raised viral load in the real world. So therefore, you would be reassured by the low ALT, and you probably would not start treatment. And so this is where we need to start thinking as a program about how to address this, because again, the viral load is not routinely available, so we're a bit blind. But once I would see that viral load, yes, I agree with the treatment with giving the tenofovir in pregnancy. As for the second question, can you go back to the second question? I think the second question was about what should be her follow-up schedule for the baby. Yeah, so the baby ideally would have the birth dose vaccine and then receive the regular EPI. And then when the baby is clocking 6 months of age, she or he should come in for their own hepatitis B test. And then obviously, if that's positive, they should be linked to care and open a file so they can receive clinical care. As far as the depression, depression is really not a well-established side effect of the tenofovir. When we used to give TLE, where we had efavirenz, we had a lot of neurovegetative symptoms. But tenofovir itself, whether it's the TAF or the TDF together with lamivudine or emtricitabine, it's really not a common thing we see, depression or depression symptoms. So I would probably be thinking it may be something more, more not related to the medication. So I would not want to change. The other reason I wouldn't change is that the alternative is just to put her on something like lamivudine alone, but that is very hard to find in our facilities for adults. So we would want to keep her on the tenofovir as much as possible. We don't often want to go on to lamivudine by itself because it's not as good at treating the hepatitis. And I think I can stop there. Thank you.
All right, thank you so much for that response.
So maybe just a clarification, Dr. Mbisa, did you say the tenofovir was started after delivery or before delivery?
The week she delivered.
So it was postpartum.
Yes.
Okay. So maybe just to add on to what Dr. Vinico said. So at this point, so before pregnancy, she would have been a good candidate, yes, for tenofovir. But I'm not sure if it was given for the mother's own treatment or whether the indication was to reduce mother to child transmission. So if it's for the mother's treatment, then you would follow the recommendations, the criteria that are there for studying tenofovir in even a non-pregnant person who has hepatitis B. So checking the viral load and all the other tests. But at this point, for someone who's already delivered, to give tenofovir to prevent transmission, I think, as we heard earlier, that most of the transmission occurs during delivery itself. So I think maybe focusing on the baby, ensuring that the baby gets vaccinated. Hopefully the baby did get vaccinated, but the mother did have risks for transmission to the baby, as was mentioned. She's HB surface antigen positive, and we don't have an E antigen, which would have been good. We don't have a viral load. Again, that would have been good to know. And also information on whether the baby received the antigen, the single antigen at birth. So that's just additional information which would have been helpful. But for her, since she's postpartum, I would use the criteria that I used for any person that has hepatitis B.
Thank you so much for that response. There's a discussion. I think someone's looking for advice. James Ngwenya. They're saying that they have a patient that's admitted with hepatitis C and hepatitis B surface antigen positive for a woman who's at 32 weeks. But unfortunately, they're unable to do a viral load, and they are asking how they should go about the management of this particular patient.
I think there is a response from Dr. Vinico, so you could probably just read that.
Okay, so he's saying if the viral load is high in pregnancy, the recommendation is to start tenofovir and continue until 6 weeks postpartum. Yes, if it were possible to monitor the viral load to verify it's dropping, that's good, but there is no resistance, so good adherence is equal to viral suppression. So for Ngwenya's, I think it was to say on your patient, he recommended that they send a message, I think, for just further discussion in terms of how to do that. So how should? Okay, there's a hand in terms of response to the question. Please go ahead and
Good afternoon. My question is, I've got a question, not actually responding to the question which was asked, though. So I don't know, maybe if I can come after it has been discussed, or I can still ask my question.
Since you've already, you can go ahead and ask your question, and if they still want to go back to the previous discussion, then we can take it up from there. So feel free to ask your question.
Thank you very much. We've had very bad internet here, so I don't know if maybe the question I'll ask, maybe it has been tackled already. I've got a concern on the treatment, the time at which we're supposed to start treatment to the patients or clients who have tested positive to hepatitis B. If I remember very well, from some cases we've had before today, the advice we've gotten when we consult is that when the liver profile is normal, is within the normal range, and when you do the scan, the liver seems to be normal. There are no signs of cirrhosis. You can not start treatment. So I just wanted to be clear if we've been given a go-ahead, more especially in pregnant women or breastfeeding mothers, to start treatment immediately, because the truth is that we do not have facilities available or instruments available to be used to do the viral load for hepatitis B. It means, let's say if it is as far as Mchinga province here in Chisali, it means someone has to be sent to Lusaka to a private hospital for them to be able to do the viral load. So I wanted your advice on that, if we are starting immediately when it is in that situation, or
Okay. Oh.
Yeah, I can respond. I can just say that no, it's not a programmatic recommendation, but as a clinician, you have that discretion. There are a lot of times when you need to make a decision for what's best for the patient in front of you. And with any medication, you have to consider safety, and then you have to consider benefits. So as long as you have considered those and you're making a clinically informed decision, I don't think you can be criticized. I hope that helps.
So there was another question in terms of whether we should give tenofovir without doing, getting renal feedback in terms of our labs, and to say what is the minimal. I mean, in areas that cannot be able to do either liver or kidney function tests, what is the most minimal lab test apart from finding out that the patient is Hep B positive? Can they do before they actually go ahead to start the tenofovir?
Yeah, I mean, we're taking a lot of cues from the PrEP program, which is taking off a lot in the last few years. So we've learned a lot from what the PrEP clinic is doing, because in a way, we have a lot of parallels. So we have clients who are HIV negative that are taking ARVs. So this is a new population. And so the PrEP clinic, I believe they will prescribe even if they can't do the kidney function there and then. Maybe they need to do it at the next visit, or maybe they get a sample, but they haven't got the results yet. They can still prescribe. And so we would recommend following that. If creatinine is not available, I think a urinalysis is also a reasonable alternative. But if you do a urinalysis and you see abnormalities, you can't ignore them. Then I think you have to then go ahead and get a creatinine before you would start treatment.
Okay,
These
so
are, by the way, these are really good questions. Thank you so much. Everyone's thinking very deeply about this. I appreciate that.
there's a hand. Unmute yourself and ask your question.
Okay. So thank you, Dr. Mbiza. I'll go back, I think, to the previous question that was there, and maybe address the technocrats on the call in regarding to hepatitis B. Several times we get these questions, and it's now being left to personal discretion on when to start the treatment or not start the treatment. Do we have the viral load? Do we have this and all those other? I would recommend that maybe we come up with guidelines that can be applied at a facility where we don't have any of these investigations, because even LFTs are not accessible in Ruangwa, LFTs are not accessible in Kaputa and all those places. Viral load is not there, but they still have patients with hepatitis B whom they need to manage. So I think when we're coming, we need to have an echo session with clear guidance for what these people need to do at that level, because I think most of them are still dark after this echo session. Thank you.
All right. Thank you.
So maybe I can just kind of respond a bit to Dr. Zimba's question, and also I'm sure my Dr. Mike can respond, because that's part of what he was trying to emphasize. So I think in medicine in general, and by this I don't mean internal medicine, but in the practice of medicine, obstetrics, surgery, and whatever, in using evidence, one usually evaluates the strength of the evidence that's available. And there are situations for which the evidence is not very strong to support a recommendation one way or another. And those are situations where the decision is left at the discretion of the provider instead of a concrete either do this or don't do that, because for some things, until it's been evaluated in a clinical trial and things like that, one could make a very strong recommendation, for example, that you do this, and then later on when studies are done, it shows that that doesn't really work. So resources would have been wasted and everything. So that's part of the reason for some recommendations being not very clear cut. It's basically a lack of evidence. To illustrate them, there's a question in the chat on C-section, whether C-section should be, let me just read it. Does C-section provide better PMTCT than vaginal delivery in this case? So what some associations like the American College of Obstetricians and Gynecologists has recommended, there's a strong recommendation not to do C-section just for the purpose of preventing hepatitis B infection, that other indications should be considered when making a decision about C-section. But the level of evidence for that is what they have as 2C, and C means that the evidence is conflicting. So it's not strong in either way, but they still make the recommendation that on its own, since the level of evidence is conflicting, it's not sufficient to make a to recommend C-section, for example, as a means of delivery when you have hepatitis B as the only reason. In other words, it hasn't been conclusively shown that it prevents hepatitis B infection. So that's just part of the reason why some recommendation may come out as vague or non-specific, is because of a lack of research and evidence into those. Dr. Vinico, you want to give additional input on that, on Dr. Zimba's comment?
No, I think the point is well taken. Yeah, the practical guidelines are needed. Guidance for facilities that don't have lab capacity are definitely needed. And yeah, those of us who are on the hepatitis task force have heard you and working on it. Thank you.
Okay, thank you so much. So we'll take that as part of our recommendation from this meeting. So I think the second last two questions which have come through from the chat is with good adherence to the percentage and efficacy and effect of TDF-3TC to Hep B virus, and at duration delta with which strain, and when should we consider failure? So adherence, so we're saying when should we consider that there is a failure if we're using TDF-3TC or treatment of hepatitis B, and what's the preferred monitoring of cure for hepatitis B surface antigen test, or is it the PCR?
Sure, I can take this one. So monitoring is with ALT. So that's why a lot of times we prefer, well, it's convenient if the person has a raised ALT when you're starting treatment, because then as you follow them, you can see if the ALT is normalizing. And if it's not normalizing, then you may consider that they're not adhering to treatment. As far as the functional cure is defined as the clearance of the surface antigen from the bloodstream, because remember from previous sessions, the virus has its life cycle inside the liver. And every time it replicates itself, it releases some surface antigen into the bloodstream. And that's what you pick up when you do the test. And so every year on treatment, we reassess the person's surface antigen test. And we do see that some people achieve the cure, and then they can be discharged from care, or they can stop treatment as long as they don't have HIV. However, I have to say that that's very uncommon. So I think at UTH, we have probably only about 5 or 10 clients like that out of hundreds. So it's a rare outcome. We don't actually counsel patients very much about it because we don't want them to get up hope. But yeah, essentially, if your facility can do the surface antigen test and the ALT test, then they can be able to monitor hepatitis treatment.
So Dr. Mbiza, maybe I can just also add to what Dr. Venico has said. Obviously, as has been established on this call, that there are guidelines that are based on, facilities or places where they are able to do so many things, and it's a bit clearer in such places. The challenge we have in our places is that most of the things that we're supposed to use as tools may not be as available. And so maybe that's where the deep end is. Like Dr. Venico said, we may have to look at what may be very practical in our setting. Now, coming back to the question of failure, yes, one can look at the phenotypic picture and biochemistry, like Dr. Venico has said, because we expect that someone who is effectively on treatment should be having a drop in for example, the liver function tests. For those who are in a place where they are able to do other more complex studies like the viral load, again, you'd see that the guidelines talk about people that by 96 weeks on treatment, if someone's viral load is still above 2,000 international units per mil, then that is a worry. It's actually referred to as persistent viremia, because then it should have been dropping. So 96 weeks and you still have more than 2,000 international units, that's persistent viremia. And there are guidelines again to look at how you approach such cases. Are they failing because they are not adherent? Are they failing because maybe they were on a poor choice initially of which drug to give? And so, for example, those who are on 3TC, you want to switch maybe to TDF or TAF if you can. There are even guidelines that you may even want to combine two more potent drugs. So that was just an addition to what Dr. Venico had mentioned. Thank you.
Thank you so much. So at this juncture, we'll have a report. Let's see how much people have learned through the time that we've spent with you. Okay, so we'll go to the first poll. Which of these is true about Hep B virus within the Zambia Extended Program on Immunization? I see the responses are just coming in faster. Okay, so we will end the poll. Let's see what the answers came through as. So we've got 67% of the people that voted answering as number 2, that the program has reduced hepatitis B prevalence down. And then we have 23% who think that increasing the rate of HPV vaccine. We have 7% that think that the HPV vaccine given at birth and 9 months, and then we've got 2%. So let's go back to what the true answer of this is. Okay. Yeah, so it shows that learning has taken place. So we move on to our second poll. So which of these is true regarding HPV mother-to-child transmission? Most HPV transmission occurs in the second trimester. 1, an extra birth dose of HPV vaccine is only recommended. Number 3, maternal viral load during pregnancy is the strongest. Number 4, women with HPV should not breastfeed their babies. So we shall end the poll in about 5, 4, 3, 2, 1. Okay, thank you so much for those responses. We've got 91% who voted for 3. Maternal viral load during pregnancy is the strongest. And then we have 6% who said women with HPV should not breastfeed. And then we've got 2% who say that most HPV transmission occurs during the second trimester. So looking at what our right answer is, which is 3, it shows that Dr. Mike Vineker's learning session has actually yielded well. So the last poll. Which is true regarding antenatal tenofovir? The goal is to suppress mother's HPV viral loads before delivery. Number 2, once initiated antenatally, tenofovir is lifelong. Number 3, HPV PMTCT and use of different types of tenofovir. Number 4, because it is prescribed for HPV. So let's take to the polls. Okay, so we end the polls. We have 92% that said the goal is to suppress the mother's HPV viral load. And then the third thought 4% thought that the HPV PMTCT use of difference. And then 2% thought that once initiated antenatally, tenofovir is lifelong. And just 1% of the people thought it's because they're prescribed. So looking at this in terms of what we had gone through, our right answer is 1. Thank you so much for those answers. Thank you for the learning sessions. I will just give it back to our experts. I see Dr. Nsokola, you're in. Maybe just a greeting to the audience, or 1 or 2 things that you would want to tell us concerning our session.
Thank you very much. I've been following, except my internet wasn't as good. It's been a great session, and so much has been brought out concerning hepatitis B. Maybe just an addition to what the other experts have mentioned is that if we can manage to monitor or to do the surface antigen as often as possible during pregnancy, let's do it. Because even when a patient the mother has acute hepatitis B infection, they can still transmit the infection to the mother. If they have the infection during the early pregnancy, first trimester, the chance is just about 10%. But the closer it is to delivery, the higher the chance. If somebody acquires the acute infection of hepatitis B within a short period before delivery, you'll find that the chance goes to even up to 60% chance of transmission to the child. So let's check for surface antigen as much as we can. That will help us to prevent transmission from a mother to child. Thank you very much. Back to you.
All right, thank you so much for that contribution. Any of our experts, just final words as we do our wrap up?
No extra words from me. Thank you.
Thank you.
Hi, Dr. Biza. Just to encourage everyone to keep being a champion, to look out for hepatitis. We have to be aware that Zambia is moderately high in terms of the classification of the burden, the disease burden, and we have to be part and active in ending viral hepatitis by 2030. The efforts will have to be cross-cutting, not only here in Lusaka, but the whole country. And especially mother to child, let's ensure that we stick to even our local guidelines. At least I'm sure most of the facilities can at least afford maybe a surface antigen. That first antenatal visit, when our pregnant women come to us, we've been routinely doing syphilis tests, HIV. Let's also remember hepatitis. Thank you very much.
Thank you. Dr. Mlenga, anything as we wrap up?
Oh, nothing much from me. Just to congratulate.
Okay. So we want to thank you, the Ministry of Health. We want to thank our experts, Hepatitis Echo Hub, that have been with us through this session. And the topic of our discussion was hepatitis B in pregnancy, and also we looked at children. So I hope you have picked 1 or 2 things. Please, let's get interactive. As already been said, we want to make sure that we end hepatitis by 2030. We are in 2022, so let's see how we count down. And please, thank you so much for tuning in. Continue tuning in into our ECHO programs. It's been a great time being with you. It's been interactive. Please ask more questions. For all the districts, different provinces that have been represented, we appreciate your efforts. We cannot do this without you, so let's unite together to end this hepatitis and to work together and share the knowledge that we have all across the board. It's been an honor. From me, your facilitator, Dr. Christabel Mbiza, obstetrician gynecologist at UTH, a registrar. I just want to say thank you. Otherwise, have a wonderful day. God bless all of you. Thank you so much for tuning in. Thank you.